Thank you, everyone. So my name is Diana Girnita. Probably many of you know me. I used to work to TriHealth until last year, and I recently moved to San Francisco. Today, we're going to talk about a rheumatology topic, of course, which is systemic sclerosis. This is a disease that unfortunately causes many problems, and we're going to go over a couple of things, a couple of clinical symptoms that people have to know to recognize in order to get the patients to us and be treated at a sooner time. So it's pretty rare disease. The incidence is about 20 cases per million. The prevalence is about 24 cases per 100K people, and it's very frequent in females, more than in males. The ratio is about 4:1, and usually the age of onset is around 30 years old, up to about 60 years old. When we talk about scleroderma, and when the residents used to come to my office, I try to make them understand that there are two different concepts. One is the localized scleroderma, which is just a patch of skin that could be involved, and the other one is the generalized scleroderma, which can be further subcategorized into limited scleroderma, which will affect just a few organs in this process. And the other one is the diffuse cutaneous systemic sclerosis. We do have other categories like systemic sclerosis seen as scleroderma, and we'll talk a little bit about that. And we also see systemic sclerosis in overlap with other diseases such as polymyositis, dermatomyositis, or lupus. A few pictures that will show you what localized sclerosis means. So as I mentioned to you, this is just a patch of skin, sometimes on the back of the patient, sometimes on the front head of the patients, and sometimes on the lower extremities. We see that pretty often, and this is not what we call systemic sclerosis. So when we talk about systemic sclerosis, and I'm going to insist that we look at this in how it presents. It could be limited or it could be diffuse, and we look at the amount of skin that is involved. Usually in the limited sclerosis, we see the extremities involved. Sometimes it can go up to the elbow or up to the knees, but in diffuse cutaneous scleroderma, we see almost every part of the body that can be involved. I'm not going to get into a lot of this pathogenesis of this disease, but I'm going to mention a couple of things. Everything in scleroderma, we think it starts with an endothelial injury, and that will trigger an immune response, which is most of the time exaggerated. A lot of the cells from the immune system come to that place, and then there is a process of accelerated deposit of collagen, which will lead to fibrosis, and that will also lead to vasculopathy and the problems that are associated with that. We're going to talk a little bit about the clinical features, because many people recognize scleroderma based on the clinical features. Probably many of you remember this picture from the textbooks about this lady with systemic sclerosis. But scleroderma doesn't involve only the skin. It can involve the vessels. As many of you know, it can involve the GI system. It can also affect the bones. But we will also talk about the involvement at the heart level, the lung level, the kidney, and also scleroderma can cause calcinosis, which is a deposit of calcium under the skin. So we'll take them one at a time, and I will show you what the classical features of scleroderma are. So you remember about this facious expression where the patients do not have any wrinkles, when the opening of the mouth is almost impossible. You remember about telangiectasias, But, you know, many of the residents that rotated with me did not know about the appearance of the skin in people of color. Because of the collagen deposition, the melatonin doesn't deposit anymore, and the skin will turn out to have a salt and pepper appearance. All right. So many times, patients with scleroderma will present with joint pain, and they will present with swelling of the hands. Sometimes they have not only puffy hands, but they can have a lot of itching of the hands. And many of these people in time, because of the collagen deposition and the skin tightening, they will develop contraction of their fingers. So the hands will look like that. Some of them, they will have these deposits of calcium, which can be very painful, and sometimes they can ulcerate, and their hands can look like this. Many of these patients, they do present with a lot of nail changes, and rarely we look to their nail folds or nail fold beds to see how they look. And we use nail fold capillaroscopy to evaluate not only the presence of the disease, but the prognosis of this disease. The more dropouts in their capillaries around the nails they have, the more severe the disease is. So I mentioned to you the calcinosis. Calcinosis can happen not only on their palms, but it can happen around their elbows or around their tibia. This is not specific for scleroderma. It can be seen in other diseases, especially dermatomyositis. Raynaud's is actually something that I draw attention many times to many people, because if a patient will develop Raynaud's in their 30s, you have to be aware that Raynaud's could be a sign of an autoimmune disease. Many patients with scleroderma, unfortunately, they develop Raynaud's actually even 10 years before you see the signs of systemic sclerosis. So in time, because of the vasculopathy and because of the advanced disease, they start to develop ulcerations, and they could lead actually not only to ulcers, but also to gangrene. And sometimes they have their fingers amputated because of ulcerations.
You can mute your, just mute it over there. Just click on that little thing.
So I think someone has to mute the phone. Yes, thank you. And in terms of musculoskeletal involvement, many of these patients will complain about joint pain, about morning stiffness. They develop deformities, as I showed you, the ankylosis. And when the disease is very advanced, they can develop tendon friction rubs. So if you put the stethoscope over their wrist or over their elbow and you ask them to move the extremities, you will actually hear the friction rub, which is a poor prognostic sign. When the disease advances because of the vasculopathy, there is an interesting process happening. And I show these x-rays to my residents because I want them to see that the third phalanx sometimes, because of the vasculopathy, starts to reabsorb. So we call that acro-osteolysis. So in these patients, because they don't have the flow, the capillaries are obstructed, the bone starts to resorb and they lose the third phalanx. The gastrointestinal manifestations are actually very, very common in patients with scleroderma. We all know about the esophageal involvement of systemic sclerosis, but actually 90% of patients, without even having symptoms, they can have involvement of the upper and lower GI tract. and they can present with a lot of reflux, and many of them will describe cough, and that's because mostly of aspiration. They can develop hypomotility, they can develop choking, they can develop strictures, and when the lower GI tract is involved, they will present with a lot of abdominal pain, bloating, many times alternation of constipation and diarrhea. They can present with small bowel bacterial overgrowth, and in very severe cases, they lose the rectal sphincter and they develop fecal incontinence. So these GI complications are not rare in these patients. And I just wanted to show you a few pictures. This is a patient with a duodenal dilatation with severe abdominal pain and bloating. This is a patient that had the esophagus very dilated. This is a patient that have the gave or watermelon stomach, which is actually very, very common in patients with scleroderma. And this is a patient that has pneumocystis intestinalis because of scleroderma too. So in terms of the lung is also one of the organs that is very commonly affected in scleroderma, and it can be affected at the parenchymal level, but also at the vascular level. And I'm sure you all know about the honeycomb pattern of the lung involvement or interstitial fibrosis, and we'll talk a little bit about those. Now I'm going to invite another resident, Dr. Adrian Juca. He has a specific interest into cardiac involvement in systemic sclerosis. He's actually conducting a PhD thesis back into Romania, and he's going to talk us a little bit about the cardiovascular involvement in systemic sclerosis.
Thank you very much, Dr. Girnita. Just a little bit so I can share my screen.
Half a mile, turn right onto Branch Hill Getting Road.
So, hello everybody. Thank you again, Dr. Girnita. It is a pleasure and an honor to be here. I hope you can hear me well. Complex, multifaceted, and with variable clinical course as previously described, systemic sclerosis is an autoimmune disorder characterized by the following triad.
Turn right onto Branch Hill Getting Road.
Can we mute the participants?
Thank you very much. So as I was saying, systemic sclerosis is an autoimmune disorder characterized by the following triad: microvascular damage, initial innate and adaptive immune response alterations, followed by the development of diffuse fibrosis in multiple internal organs. Historically speaking, Heine provided in 1926 the first description of cardiac disease in scleroderma, the heart being one of the most frequent affected internal organs alongside the lungs and kidneys. From a general perspective, systemic sclerosis can cause two types of heart disease, either primary or secondary. Primary cardiac disease directly involves the myocardium, pericardium, coronary arteries, conduction system, and valvular structures, with the mention that the valves are the least affected site in the heart. But it can also be secondary to renal and pulmonary comorbidity, be it vascular or interstitial. This multitude of potential tissular targets leads to a polymorphic expression of the disease. Myocardial fibrosis, myocarditis, restrictive cardiomyopathy, ventricular dysfunction, heart failure, coronary disease, valvular regurg, rhythm and conduction disturbances, and pericardial disease may all be seen, and the clinician must be aware of their presence. But the hallmark of the disease remained the depressed myocardial function and cardiac complications generated by pulmonary hypertension. Despite scleroderma being a rare disease, as Dr. Girnita said, overt cardiac damage is seen in 1/3 of cases, but the true prevalence is much higher, taking into account the high rate of coexistent comorbidities that patient has that may lead to false identification of symptoms, alongside data provided by autoptic studies that demonstrates a prevalence rate situated between 21 and 100% of cases. Still, most patients present with subclinical disease. In the past decades, the heart remained the generator of a constant number of deaths in this population, while pulmonary and renal complications declined gradually. Still, cardiac and pulmonary comorbidity are the most important causes of death in the systemic sclerosis population, as data from the Spanish Registry of Systemic Sclerosis demonstrates a threefold increase in cardiac-related deaths in the last 10 years. Cardiac disease secondary to scleroderma is a clue for the presence of an aggressive phenotype of the systemic disorder, as mortality risk is elevated more than 5 times and 5-year mortality rates regarding primary myocardial involvement reach up to 70%, with global cardiac dysfunction being incriminated in 25 to 30% of total deaths in this population. Despite their tendency to coexist, the relative risk of mortality from cardiac causes is higher than pulmonary or renal ones. Typical histopathological features of scleroderma heart disease include disseminated areas of myocardial fibrosis and normal coronary arteries, but with concentric intimal hypertrophy that leads to a reduction of the coronary flux reserve. Moreover, some authors documented the presence of an active inflammatory myocardial substrate which is linked with recent onset heart disease. Though cutaneous features are distinctive in systemic sclerosis, the underlying degree of visceral damage will determine the prognosis of the patient. In the diffuse cutaneous subtype, there is a high rate of cardiac complications doubled by a severe phenotype of myocardial fibrosis. Pulmonary arterial hypertension is severe and interstitial lung disease has an early debut. Immunologic profile is characterized by the presence of anti-SCL70 and anti-RNA polymerase type 3 antibodies. At the other end of the spectrum lies the limited cutaneous subtype, which has a lower rate of cardiac complications, though recent data show that it might be more frequent than previously thought, and myocardial fibrosis is not that severe. PAH is also frequent, but interstitial lung disease is insidious and usually mild. Immunology is dominated by the presence of anti-centromere antibodies. One important remark must be made regarding conduction disturbances, which are equally distributed among both disease subtypes. As previously stated, primary myocardial involvement and pulmonary arterial hypertension are two of the most important cardiovascular complications of systemic sclerosis. Data obtained by multiple regression analysis from the EU-STAR database have identified the following as independent risk factors for primary myocardial involvement: advanced age, rapid progression of skin thickening, male gender, diffuse cutaneous subtype, duration of disease, digital ulcers, simultaneous renal and muscular impairment, disease activity score, pulmonary fibrosis, and pulmonary arterial hypertension. Moreover, male gender, older age, digital ulcers, lack of administration of calcium channel blockers, and myositis are independent risk factors for future left ventricle dysfunction. Virginia Steen and colleagues demonstrated that the presence of physical stress-induced myocardial perfusion defects is able to predict the future risk of death or cardiac dysfunction. Also, nail fold capillaroscopy is useful in assessing the future risk of myocardial involvement, as reduced capillary density is associated with a lower functional status, evaluated by NIHA class. Immunology is also able to provide insight into the future risk of myocardial involvement, as several antibody patterns have been associated with this disease subtype. Regarding risk factors for pulmonary hypertension, most important data are derived from Pharos clinical trial and REVEAL registry. Patients older than 60 years, male gender, clinical factors, laboratory biomarkers, small distances walked at the 6 minutes walking test, altered pulmonary function, and parameters derived from right heart catheterization are all able to identify patients with future risk of pulmonary hypertension. In the following slides, I would like to present a clinical case that best describes the dominant cardiac phenotype seen in scleroderma heart disease. It is the case of a 57-year-old male patient, active smoker, who is referred for evaluation in our center in the setting of dyspnea and fatigability at moderate exertion levels. He also complains of polyarthralgia of the small joints, dysphagia for solids, and productive cough for the last 2 months. His medical history begins 20 years ago when he started developing Renal's phenomenon. In 2019, because of bilateral malleolar discomfort and hand telangiectasis, he is diagnosed with diffuse cutaneous systemic sclerosis with help of immunology, capillaroscopy, and positive cutaneous biopsy. 6 months later, he started exhibiting moderate to low exertion dyspnea, followed by, at the beginning of 2020, for the BMP has a high value as a marker of heart failure, but with normal left ventricle ejection fraction and previously unknown akinesia of the infero and inferolateral left ventricle walls. Current evaluation identifies a patient with sclerodermic phenotype with Velcro rails, regular heart sounds, but with a mesotelesystolic murmur with grade 2 out of 6 in the tricuspid area. Laboratory results show a significant increase in the BMP value from the previous determination and leukocytosis. Resting ECGs in sinus rhythm with normal QRS axis, but with left atrium enlargement and previously unknown bifascicular block, formed by a combination from atrioventricular grade 1 block and complete left bundle branch block. Holter monitoring identifies a high burden of ventricular arrhythmia with almost 7,000 premature ventricular beats, with tendency to systemize in bigeminy, trigeminy couplets, and even runs of non-sustained ventricular tachycardia. But most importantly, there's an alternating change in the morphology of the QRS complex between left bundle branch block and right bundle branch block. Transthoracic echocardiography identifies a non-dilated left ventricle with moderate systolic dysfunction and segmentary dysfunction in the akinetic territories. Systolic pulmonary arterial pressure measured by means of transthoracic echocardiography appears to be normal, and there is a reduction in the left ventricle global longitudinal strain. Because the patient presented with a previously unknown major conduction disturbance on the resting ECG and that transthoracic echocardiography identified the akinesia of the lateral and inferolateral left ventricle walls, there was need for coronary angiography. It was performed and revealed a normal right coronary artery, but that the circumflex artery you can observe a 80% stenosis at the origin of the first marginal, stenosis which was treated by means of implanting of a drug-eluting stent. Because the patient suffers from systemic sclerosis, he is at subsequently risk for future pulmonary hypertension. So, right heart catheterization was performed, and it effectively excluded the presence of pulmonary hypertension by measuring a mean pulmonary arterial pressure of 20 millimeters of mercury. Treatment consisted from guideline-directed medical therapy with beta blocker, loop diuretic, ACE inhibitor, dual antiplatelet therapy for the implantation of a drug-eluting stent, statin, and mycophenolate mofetil. Future workup should have consisted from cardiac MRI and repeated Holter monitoring for establishing a firm indication for cardiac pacing, but sadly the patient was lost from follow-up. Take-home messages regarding sclerodermic cardiomyopathy are that this is an under-recognized and under-diagnosed clinical entity that has initial phases that evolve asymptomatic or occult. Though being asymptomatic, it is still a major predictor of mortality, as survival rates at 5 years reach 24%. Multimodality imaging, especially advanced echocardiographic techniques and cardiac MRI, are the central pillar for early detection, but the clinician must also be aware of potential conduction and rhythm disturbances. Optimal management of these complex cases is achieved by a multidisciplinary approach consisting from cardiologist, rheumatologist, and pneumologist. Thank you very much.
Thank you, Adrian. So
I will stop sharing.
Yes.
Okay, perfect.
And I will share my screen now again. So we'll go ahead a few slides. So you all heard about the cardiovascular involvement, and I'm very happy to tell you that many of the residents that rotated in the clinic, they find out about how important it is to screen the patients with autoimmune diseases for cardiac changes or cardiac involvement, because many of these diseases will affect the heart. We will talk further about the renal involvement in scleroderma renal crisis. And as you all know, this is something that happens to patients with systemic sclerosis, and it can prevent as an acute renal crisis after prolonged hypertension, and it's very unlikely to present with normal blood pressure, but it happens in 10% of patients. You will see scleroderma renal crisis in patients with normal blood pressure. 20 to 25% of patients with scleroderma renal crisis will develop renal involvement. And it happens usually in the first 5 years of disease. And unfortunately, the prognostic after the development of renal involvement is really poor. The mortality is actually between 30 and 50% in about 5 years. So there are some risk factors that people have to be aware. First, the diffuse systemic sclerosis and the initial phase of the disease. If the patient has tendon friction rhabs, that they are at increased risk of renal involvement. If the patient received steroids, and especially prednisone in about 20 milligrams, so we consider that more than 20 milligrams prednisone per day, it's actually a risk factor for these patients with diffuse sclerosis to develop renal involvement. And the presence of the anti-RNA polymerase III antibodies is another risk factor for scleroderma renal crisis. So some of you might remember that we had a very interesting case of scleroderma renal crisis in a lady that was around 60 years old, and she presented to the hospital with abrupt onset of hypertension, and she had a rapid deterioration of renal function. Interestingly, she was never diagnosed with scleroderma before, and she was actually going to see different doctors for joint pain. When she was admitted in the hospital, unfortunately, initially it was thought that it is TTP, but eventually we figured out that she developed scleroderma renal crisis. She actually had systemic sclerosis, an aggressive form of skin disease that caused her to have the renal involvement. Before she developed the scleroderma renal crisis, she actually got a pretty high dose of steroids, and that dose of steroids was given to her because of the joint pain. And, luckily, we diagnosed this lady. One of the residents that was in the clinic with me recognized the case. They put the consult, and we figured it out that this lady had scleroderma renal crisis, and we saved her life, and we saved her kidneys. So we'll talk a little bit about the limited cutaneous systemic sclerosis. You all know about CREST syndrome, and I'm not going to go over this mnemonic, from CREST, calcinosis, Raynaud's, esophageal dysmotility, sclerodactyly, and telangiectasia. Everyone knows about that. I want to remind you about the fact that most patients with scleroderma or systemic sclerosis, they do present with a positive ANA. And actually, the lady that I just mentioned, she had a positive ANA, but she didn't have any of the other antibodies that are specific in scleroderma, not initially. So what is characteristic for the diffuse systemic sclerosis is the presence of SCL70 antibodies or topoisomerase 1 and the RNA polymerase IIIs. We found them pretty often in diffuse forms of scleroderma. The limited form of scleroderma, we see the anti-centromere antibodies more frequently, and rarely we could see the SCL70 antibodies. In 2013, because not all the cases with systemic sclerosis present straightforward, in 2013, the ACR came up with some criteria to diagnose. So basically, you have to come up with a score, and if the score is more than 9 or equal to 9, then that's a definite diagnosis of systemic sclerosis. But many times, if you see the skin involvement more than the MCP, that's a criteria that is sufficient to diagnose diffuse systemic sclerosis. But if you don't have that, then you can search for vasculopathy signs, or you can look at the nail fold, or you can look to see if they have pulmonary hypertension or the presence of immunological markers like the presence of the antibodies. Adding those numbers, and if you come up with a number, again, more or equal to 9, it's going to make you the diagnosis of systemic sclerosis. Now, I mentioned in the beginning about the systemic sclerosis sine scleroderma. This is a subset of diffuse sclerosis, which actually does not involve the skin. These patients will have all the internal manifestations of systemic sclerosis. They will have the antibodies that are specific for systemic sclerosis, especially the positive ANA, the positive anti-centromere or positive anti-SCL, sometimes anti-RNA polymerase 3. So if you have a patient with interstitial lung disease that doesn't have other reasons, I would recommend you to look for systemic sclerosis sine scleroderma. Now we'll talk a little bit about the clinical course of the disease, because many times people, they ask me, what kind of prognosis do I have? So this is a diagram that will show us how the limited sclerosis evolves compared to the diffuse systemic sclerosis. So usually those patients that will be diagnosed with limited systemic sclerosis, they will present with Raynaud's phenomenon. And in 5 to 10 years, they can develop the other symptoms like GI involvement or interstitial lung disease, but mostly pulmonary artery hypertension. And that's developing in about 10 to 20 years. So the extent of the disease is longer. The course of the disease is longer. In diffuse systemic sclerosis, everything happens in the first year. Many of these patients will present with Raynaud's, will present with thickening of their skin, will present with GI involvement, musculoskeletal involvement. They will have the presence of antibodies, and very rapidly, in about 1 to 5 years, they can develop interstitial lung disease, and they also are at very high risk to develop renal crisis. We're going to talk a little bit about treatment, and I just want to make you aware about news or things that are new for scleroderma regarding the treatment. We'll talk based on the involvement of the disease. So if the disease will involve the skin, many of you know that in the past, all we had was cyclophosphamide or methotrexate. We still use that, but in the last 10 years, mycophenolate mofetil started to become the standard of care. There are studies, many of them, they compare the cyclophosphamide with mycophenolate mofetil, and what they observe is that mycophenolate is not inferior to oral cyclophosphamide, but actually has good results and persistent results after 12 months of use. Many times patients will achieve good response with cyclophosphamide if it is used daily for about 12 months. But after 12 months, many of patients do not respond very well to cyclophosphamide. In the case of mycophenolate mofetil, this response is prolonged up to 24 months, and at least these are the results that we have from the studies. And the toxicity of MMF compared to oral cyclophosphamide is much lower. When we talk about Raynaud's, many of these patients will be advised to use the conservative measures, and we use calcium channel blockers. Sometimes I recommend topical nitroglycerin ointment, and just in severe cases, and I tell you it's very hard to approve that, we can use the phosphodiesterase inhibitors like sildenafil for these patients or bosentan. But again, this is very hard to approve if they don't have a diagnosis of pulmonary hypertension. I had a couple of very severe cases of Raynaud's, and one of them ended up doing the digital sympathectomy, and one of the hand surgeons from TriHealth did that very successfully. So don't disconsider this method if you have a patient with severe Raynaud's. The gastrointestinal manifestation, we basically educate them and we can treat them for the reflux. We can use motility agents. And obviously, if they have bacterial overgrowth, we treat that. So for the lung, I'm not going to insist much. If the patient has interstitial lung disease, I'll present you one of the landmark studies. But if the patient has pulmonary arterial hypertension, like Adrian said, we use calcium channel blockers, we use fluid and volume controls, and just in patients with, demonstrated pulmonary artery hypertension by a right heart cath, we can use specific therapies like prostacyclins, or we can use indel to address this complication. In interstitial lung disease, what we had in the past was cyclophosphamide, which was used monthly IV or was used daily oral. But lately, again, mycophenolate mofetil wins the market, I would say. And I will present you a landmark study. In 2016, it was published in Lancet, a randomized controlled, double-blinded, parallel group trial that compared cyclophosphamide with mycophenolate mofetil. The study ran over the course of 24 months and included about 146 patients, which again were randomized. So, both of these drugs showed that they had achieved the primary outcome, and that means that they were able to reduce the decline in the pulmonary function. But they were not superior to each other. So cyclophosphamide was used for 1 year, and mycophenolate mofetil was used for 2 years. But what was shown, despite the fact that mycophenolate did not show superiority, it was that people tolerated much better mycophenolate, and the safety profile was much better, and the survival probability was better in those with in the mycophenolate arm compared to cyclophosphamide. There is a new treatment for interstitial lung disease. I'm sure many of you heard about that. This is a tyrosine kinase inhibitor, which was shown to have antifibrotic and also anti-inflammatory effects in preclinical models. So in 2019, in New England Journal of Medicine, it was published this study that included 576 patients with interstitial lung disease related to systemic sclerosis. They had that demonstrated on high-resolution CAT scan, and those patients had to have at least 10% of interstitial lung disease. And they gave those patients 150 milligrams of this drug called OFEV, or nintedanib. And this was administered orally. What they look is if this drug will actually help in reducing the decline in pulmonary function. So it was a successful study because they were able to show that those people that received this drug, OFEV, they actually showed a decrease in the pulmonary function, but it was prolonged. It was less compared to the people that received placebo. However, in this study, only 50% of the people had diffuse cutaneous systemic sclerosis, where we know that interstitial lung disease is more aggressive, and about 50% of people received mycophenolate before the study. But independent of that, after they adjusted, they saw the benefit of administering this drug. And although they thought this drug is antifibrotic and it's going to help with the skin, it did not show that in patients was beneficial for the skin. The most common side effect was diarrhea, and many people from the study dropped or had hard time to tolerate the medication because of diarrhea. Now, if you run out of options, I think rituximab remains also a good option. We don't have many studies. Most of the studies that we have are very small, but we do have this study that was published in 2015 on 63 patients. This was a case control study, and it was done in Europe. And they look also at the skin and the lung fibrosis. And what they have shown is that actually both groups improve in terms of the skin and in terms of the interstitial lung disease. And this was statistically significant. And I myself have never used rituximab, but I think that seeing those results when everything else fails, I think this remains a good option for our patients. And let's talk a little bit about scleroderma renal crisis. You probably all know that ACE inhibitors have dramatically changed the incidence, but also the outcome. We use captopril and enalapril. Those are the most studied ACE inhibitors. And despite the use of those, up to 30% do not respond. And 75% of patients will require dialysis in the first 24 months. And actually 50% of those will remain on dialysis. So that's why it is recommended to avoid to do a kidney transplantation in the first 24 months. This is the largest study that I was able to find that included 110 cases of scleroderma renal crisis. Of course, it's a retrospective study. It is very hard to find and randomize patients with scleroderma renal crisis. And out of those 110, 108 were treated with ACE inhibitors. 41% of them ended up on permanent dialysis, and unfortunately the mortality was very high. And as I said prior, 59% survival at 5 years, which looks dramatic to me. And the mortality was higher in men. So these are the poor prognostic factors for scleroderma renal crisis. If you have diffuse skin disease, if you have involvement of the lung, at the heart, if you are older at the age of onset, and if you have anemia, those are poor predictors after a scleroderma renal crisis. So again, we want to emphasize that the introduction of ACE inhibitors kind of shifts the paradigm. Initially, the mortality cause for patients with scleroderma was scleroderma renal crisis, but now over the last 30 years, pulmonary hypertension and interstitial lung disease are the leading cause of deaths for people with scleroderma with systemic sclerosis. So this is something that I want to bring to your attention. This is something new. This study was published in the beginning of 2018. In the past, there were 2 other randomized control studies that evaluated the benefit of doing bone marrow transplantation in patients with severe cases of scleroderma. And before, the trials that they ran before were run by the Pittsburgh Center, and they included a low number of patients, but they also they did not use a myeloablative transplantation. So this study actually compare the use of cyclophosphamide with a new way of autologous stem cell transplantation. So what they did, they myeloablate, and they used the stem cells after this myeloablation, and they compare this type of bone marrow transplantation with cyclophosphamide. And you know, although the study is still small, they had 36 patients in the myeloablative autologous stem cell transplantation group compared to 39 patients in the cyclophosphamide group. And the cyclophosphamide was given IV. They were able to show that the intention to treat was superior in the transplantation group compared to the cyclophosphamide group. And the event-free survival was also better in the transplantation group. However, the mortality was about 3% at 54 months and 6% at 72 months. And that was somehow expected for this kind of study. In the end, I want to draw attention about scleroderma mimickers. I tell my residents about the nephrogenic sclerosis, the eosinophilic fasciitis, or the scleromyxedema that we see in patients with diabetes. And although they look like systemic sclerosis, these are not the same disease. So in the end, I would like to thank you for this opportunity, for the opportunity to work with these wonderful residents, with the whole program, and with Dr. Friström and Jennifer. And I wanted to show you that I'm very proud of those 4 people that all match into rheumatology, and most of them, they choose rheumatology after they rotated with me. Thank you. And I'm happy to answer any questions.